Atlantoaxial subluxation and atlantoaxial dislocation. Dislocation is the displacement of bones that form a joint, and a joint is where two or more bones meet. In a dislocation, the surfaces of bones that normally articulate with each other to form the joints no longer line up correctly, and none of the joint surfaces are touching, and the subluxation is partial dislocation, so some contact remains between the joint surfaces. Types of atlantoaxial subluxation are mainly anterior and rotatory subluxation, and there is posterior subluxation, which is rare. Here is the atlantoaxial joint, and here is the atlas, and here is the axis. And as you see, and we have to know that we have three main synovial joints between the atlas and axis, two lateral synovial joints, and one median synovial joint. Ligaments that connect the axis to the atlas. The strongest ligament of the spine is the transverse ligament and is the most important even in classification of the coming types of subluxation. Atlantoalar portion of alar ligaments and the descending band of cruciate ligament. Here we can see the sagittal section, here is the transverse ligament, here is the descending band of the cruciate ligament, and for the atlantoalar portion of alar ligament it can be seen in the coronal section. Atlantoaxial rotatory subluxation. Rotatory deformity at the atlantoaxial junction is usually of short duration and easily corrected, but rarely the atlantoaxial joint locks in rotation, and in such situation it's called the atlantoaxial rotatory fixation. It is usually seen in children. The etiology, as any etiology, can be divided into congenital, traumatic, inflammatory, neoplastic, and miscellaneous. And the most important here is the infectious part of the inflammatory division, which is called Grissel syndrome, where inflammation may cause mechanical and chemical injury to the facet capsules and or the transverse ligament. And also there is minor trauma and sometimes spontaneously occur. The vertebral artery may be compromised in excessive rotation, especially if it is combined with anterior displacement. Mechanism of subluxation. The mechanism of irreducibility is poorly understood, and with an intact transverse ligament, rotation occurs without anterior displacement, and if the transverse ligament is injured, there's liability for anterior displacement and accordingly neurologic injury. Posterior displacement is rare. The classification of atlantoaxial rotatory subluxation, depending on the transverse ligament integrity and the atlantodental interval and direction of dislocation, if there is posterior or not. The type 1, the transverse ligament is intact and the distance is less than 3 millimeters. Type 2, slightly injured and the distance 3 to 5 millimeters. Type 3 and 4, there is deficiency of transverse and alar ligaments, and in type 3 the distance is more than 5 millimeters. And type 4, there is posterior change of atlas. Here's type 1, the distance is normal, the transverse ligament is intact. Here's type 2, partially injured transverse ligament and the distance is 3 to 5 millimeters. Type 3, distance more than 5 millimeters and injury of the alar ligament and transverse ligament. Here's also injury of both ligaments and posterior dislocation, posterior subluxation. Clinical findings. The most important is to remember the Cook-Robin bird. The patient is usually young and the neurologic deficit is rare and there is pain in the form of neck pain or headache. The deformity, which is called the Cook-Robin deformity, head position or deformity, is 20 degrees lateral rotation, a lateral tilt to one side, 20 degrees rotation to the other side, and slight flexion 10 degrees. The brainstem and cerebellar infarction and even death may occur if there is compromise of circulation through the vertebral arteries. Here's the deformity, here's the Cook-Robin bird, here's the Cook-Robin head position, flexion, lateral tilt, and rotation, flexion, lateral tilt, and rotation. The imaging X-ray findings may be confusing, and it includes there are some pathognomonic findings on AP cervical spine X-rays, but it's important to know that the confirmatory findings are found in CT and MRI also. In severe cases, frontal projection of C2 with simultaneous oblique projection of C1. Less severe cases, C1 lateral mass appears larger and closer to the midline than the other. Asymmetry of atlantoaxial joint and the spinous process of axis is tilted in one direction and it is not specific, even occurs in torticollis. Here we can see the eccentric position of the odontoid process. We can see the distance here is wider than here. We can see here the rotation of C1 over C2 and the elliptical shape of C1 arch. Here in CT, axial CT, we can see the rotation, and this one is Fielding type 2 because the distance is more than 3 millimeters, 3.3 millimeters. Here we can see in 3D view the atlantoaxial rotatory subluxation. Here's the MRI. The coronal MRI shows the lateral tilt and the axial MRI shows intact transverse ligament. The treatment. Grissel syndrome includes infection, so we have to take an antibiotic. Antibiotics are taken for the causative pathogen with traction and then immobilization for the subluxation as follows. Fielding type 1, soft collar. Fielding type 2, Philadelphia collar or SOMI, which is sterno-occipito-mandibular immobilization as in this view, and the halo vest for type 3 and 4. After 6 to 8 weeks of immobilization, check the stability with flexion and extension X-rays, and surgical fusion is indicated for residual instability. Here is the traction. If treated within the first few months, the subluxation can usually be reduced with gentle traction. In children, the traction starts from 7 to 8 pounds, increase to up to 15, and in adults start by 15 and increase up to 20. If the subluxation is present after 1 month, traction is less successful. Active left to right neck rotation is encouraged carefully in traction. If reducible, immobilization in traction or halo is maintained for 3 months. Surgical fusion, subluxation cannot be reduced or that occurs following immobilization should be treated by surgical arthrodesis after 2 to 3 weeks of traction to obtain maximal reduction. So traction is mandatory even if fusion is indicated. The usual procedure is C1 to 2 fusion unless other fractures are present. Fusion may be performed even if the rotation between C1 and 2 is not completely reduced, and in such a situation we have to do staged procedure. The first step is to do transoral odontoidectomy and unlocking of the locked C1 to vertebrae. So the first step is transoral unlocking, and after that we have to do a second stage posterior C1 to fusion. Here's the transoral odontoidectomy, C1 anterior arch excision, then odontoidectomy, and here's the C1 to fusion. As you can see here, the C1 to fusion, C1 lateral mass and C2 transpedicular screws. The trajectory, as you remember, it was discussed before. The entry point here is the inferior part of C1 lateral mass, and the trajectory is 17 degrees medially and 22 degrees superiorly. And the C2 pedicle screws, the direction medially is 20 to 30 degree and also vertically superiorly 25 degrees. The anterior atlantoaxial subluxation the causes either from transverse ligament injury or odontoid incompetence. Presentation: 1/3 of patients with anterior atlantoaxial subluxation have neurologic deficit or die. Presentation: neck pain is common. There are no specific patterns to the pain that are characteristic. The rule of Spence. How to calculate in general? The outer edges of the lateral mass of C1 shouldn't exceed over the outer edge of C2, which is called hangover. On AP or open mouth, as we see here, the lateral mass of C1 and lateral edge of C2, and this is the normal position at the same line, this white dotted line. If there is hangover, you will find hangover here, C1 over C2, and if it is more than 7 millimeters, the sum of both sides more than 7 millimeters, it is suggestive of transverse ligament disruption. The atlantodental intervals. The atlantodental intervals are anterior, posterior, and lateral atlantodental intervals. When we say the term ADI or atlantodental interval, usually refers to the anterior atlantodental interval. There is also, as we mentioned, others. The distance between the anterior margin of dents and the closest point of anterior arch of C1 on the lateral cervical spine X-ray, and it should be ranging and it should range from 2 to 4 millimeters. An abnormally increased ADI is suggestive of subluxation. Here's the atlantodental interval with the red line. Here's the anterior atlantodental interval, and here's the posterior atlantodental interval, also named as the space available chord. The anterior atlantodental interval, as we mentioned, shouldn't exceed 4 millimeters, from 2 to 4 millimeters, and whenever the posterior atlantodental interval is less than 14 millimeters, the patient is at risk of neurologic injury. The V-shaped pre-dense space, widening of the upper space between the anterior arch of C1 and the odontoid process on lateral cervical spine flexion X-ray. It is not known if it is increased, if this increased mobility represents elongation or laxity of ligaments. The most important to differentiate in pathology if there is increased atlantodental interval or not. The evaluation and diagnostic modalities. Both CT and MRI are recommended to evaluate fractures and transverse ligament injuries with bony attachments. Here we can see the CT. Here we can see the atlantodental interval increased. Here is also increased. It is more than 5 millimeters here, 5.7 millimeters. Here we can see the sagittal T2 MRI, and also the injury for the ligament is even evidenced by the widened anterior atlantodental interval. The integrity of the transverse ligament can be assessed directly or indirectly. Indirect assessment through the rule of Spence, as we mentioned, and the atlantodental interval, as mentioned before, and the direct assessment through the MRI, as the rule of Spence missed 60% of transverse ligament injuries, which can be picked up through the MRI. The CT may demonstrate bony injury in the regions of transverse ligament insertion to C1 tubercles. Dickman classification. So we have Fielding and Hawkins classification in rotational part, and we have Dickman classification for anterior atlantoaxial rotatory anterior atlantoaxial subluxation. The Dickman classification depends on the transverse ligament disruption Here we can see the anatomical disruption, which is type 1, and here's the physiological disruption, which is type 2. Anatomical disruption type 1, where there is tear of the transverse ligament itself without any bony injury for the transverse ligament. Type without bony or osseous component in the area of the transverse ligament insertions. Type 1, the injury is mid-substance, it's to be called type 1A. If it is in the osteoperiosteial area, it is called type 1B. And the Dickman type 2, there is detachment of C1 tubercle to which the transverse ligament is attached. Treatment. If the transverse ligament, for the transverse ligament disruption, there is one approach as it is related to the Dickman classification. All Dickman type 1 to be fused. Fuse Dickman type 2 that are still unstable after 3 to 4 months of immobilization. Fusion is recommended with irreducible subluxations. If C1 is intact, C1 to fusion is adequate. If C1 is fractured, occipital cervical fusion may be needed. For situations where there is fracture of C1 and C2, it will be mentioned with each. And thank you.